Everyone, thanks for coming to our respiratory grand round. So today's presentation is all about pneumonia, and you've probably seen lots and lots of people coming in the last few months with pneumonia. The spring season, January to really May, June, is very, very high incidence of pneumonia every year, and this year it's particularly high with COVID prevalence as well. So we're going to talk a little bit about updates on pneumonia, things that you probably haven't learned about in medical school, information that's come through in the respiratory journals over the last couple of years. And then we're going to talk about the BTS audit that runs every year in the UK, the results of our last audit, and then what we're going to be doing this year to try and ensure we've got standardized practice. Right, so I'm just moving forward. So let's just check you can all see my presentation. It's just disappeared from my screen. So, okay, can you all see, Oliver, if you could just let me know if everyone can see the first slide.
There's nothing at present, but it does look like it's about to
come
load.
through. Yeah, it just disappeared for a second there.
Oh, here it is. It's back again now.
Right, great.
Okay.
Okay, so today we're going to talk about what pneumonia is, what's the pathogenesis behind pneumonia, and then we're going to talk about how you risk stratify those patients who are at highest risk of dying from this diagnosis, and how our therapeutic interventions can make a big impact, but then it needs to be standardized to affect the whole population. And then finally, we're going to talk about long-term implications from pneumonia that you may not realize, particularly for those patients over the age of 50. And then our results of the BTS audit and what we're going to be doing here to try and improve practice for the future. So this study, published in 2011, highlighted the fact that pneumonia is actually a very serious acute medical illness, which should have the same incidence, should have the same priority as an acute ST or non-ST elevation MI. And this was quite interesting because back then they recognized that the mortality rate was quite high, and yet we weren't treating these patients within the 4-hour target, which of course heart attacks are treated. And concerns were raised around the country and around Europe of the fact that we weren't treating it as a real emergency, and perhaps we should do. So the ERS and obviously the BTS became concerned about this, and we started doing more and more audits on it. And if you look at what causes pneumonia, there are many, many studies, and these are some of them. And you can see in the majority of European journals, they found that streptococcal pneumonia is the most common throughout Europe. And the only outlying study was one done in the US, and they thought that perhaps viruses were slightly more common and streptococcus was less common. However, when you look at the time frame that they were looking at, their patients were being studied at a much earlier stage, and the European patients were presenting perhaps on day 7 or day 8, but the US patients were being tested a lot earlier. And the results are quite interesting. It shows that usually a virus triggers the pathway to allow bacteria into the respiratory tract and then cause pneumonia. So when the US study was repeated at a later interval, they found, of course, streptococcus was the most common cause. However, you need to keep your mind open to other causes, and this is why taking a history in respiratory medicine is so important. Now, patients who have alcoholism, anaerobes, unfortunately, are very common because they often vomit and they inhale the vomit, and anaerobes from the stomach cause it. In this area of Hastings, we have a very poor uptake from dental care, and every year we have a patient who comes into hospital with pneumonia secondary to dental disease, and we have a patient at the moment on bed ward who's got an empyema actually from 8 rotten teeth that he didn't have treated during the pandemic. So always take a good clinical history, examine the mouth, and consider whether dental disease or recurrent reflux might be causing this. Our COPD patients, of course, are much higher risk. They get streptococcus, but they also get Haemophilus influenza and M. catarrhalis. So that's a good thing to recognize for your MRCP exam when you're being vivid. Patients in nursing home get streptococcus, but they tend to get other things too, like Haemophilus and anaerobes as well. And then if patients have been in an area where Legionella is very common, you need to consider that as a diagnosis. Always consider environmental allergens, environmental pathogens such as chlamydia, psittaci, if the patient keeps pigeons and have high exposure to birds. So the BTS and the recommendations around the world is that you should do specific microbiological tests based on the severity score of the patient. So if the patient's an outpatient, most of the time you don't need to do anything at all, because they'll get better. They're obviously presenting at an early stage, and straightforward antibiotics should be enough. However, if the patient's attending A&E and they're coming into the hospital, it's often because they're presenting later, and often because the GP is already treated with antibiotics. So you do need to send off a sputum sample, particularly those, even those in low severity scores, because they may be presenting with a bug that's resistant to the standard antibiotics that we give. For example, MRSA is more common in nursing homes, and our patients on azithromycin, our long-term COPD patients, often have resistant bugs as well. And as the severity score goes up, you need to think of more and more unusual causes of pneumonia, and that's why we send the Legionella in stage curve score 3 or higher. So we're going to discuss some interesting clinical cases today, and if you could put your responses in the chat, then Oliver will highlight your questions and your answers. So this is our first case. She's a 45-year-old lady who presented with cough and a fever for 3 days. She's got a 10-pack smoking history and a past medical history of diabetes. Her SATs were 94, her rest rate was 14. She attended A&E with a temperature of 38, and her blood pressure was normal. Her urea was 6, her creatinine was normal, and her white cell count was 13. Her COVID swabs were all negative. She said she hadn't traveled anywhere, and she hadn't been in contact with anyone with COVID. So that's her clinical history. And also she hadn't had antibiotics from her GP, we should add in there. So based on what I've just discussed, what does everyone think about whether we should admit her or treat her and send her home? So if you could put your responses in the chat, and Oliver, if you could tell me how many people have said she can be treated, how would we treat her and send her home?
Sure, will do.
Other responses you could give, I have listed here, are admit for antibiotics or do a CT thorax. So if you could put your answers in the chat box, either treat and send home, admit to the hospital for antibiotics, or do a CT thorax. And if I go back a slide, you can see the clinical history again if you're coming in slightly later and didn't see the first slide. Have we got any answers yet?
No responses as yet.
Okay, well, we can talk about them all then. So based on the clinical history, we can see that her curve score here is going to be 0, isn't it? She's less than 65. Her urea is normal. Her rest rate's 14, that's normal. The blood pressure is normal, and she's not confused. But importantly, there are no other problems. She hasn't got COVID. She hasn't got COPD or other medical problems causing her symptoms. She doesn't have mental health problems. She is able to take her medications orally and has good social network, and she's competent to be able to make clinical decisions. So if she does get worse, she's able to come back. So based on our BTS curve 65 score, you can see here, she actually has a very low score, despite having quite a nasty looking chest x-ray and nasty symptoms. Her actual curve score is quite low at 0 to 1. So we could treat her at home. And these guidelines go back a long time. This one goes back to 2002. And it stood the test of time. It's a good guideline, and it's appropriate. And however, like in everything in medicine, you can't just go on a guideline. You need to use your clinical skills. So when you're taking history from patients with pneumonia, always think about their social network and whether they're able to look after themselves at home and follow your instructions and take the antibiotics and have good compliance. And if you're concerned the patient has maybe dementia or a poor social network or not coping at home, of course, you may have to admit them for other reasons. However, this lady has no social service concerns. She doesn't have any other medical problems that would make us concerned that she would need hospital treatment. And she hasn't had antibiotics either. Remember, some of our patients, if they presented with her X-ray after a 7-day course of antibiotics given by the GP, we probably would admit because we'd be more concerned about a resistant bug that hadn't responded to antibiotics. So always use your clinical skills and always think of these questions when you're admitting your patients or making a decision about discharge. And around the world, other countries use different scores. And this is a score that's called Port Prediction Rule, and it's used in the United States. And you can see it's a little bit more complicated. And that's because when they admit their patients, they use the computer right from the start. So they admit the patient putting all the data into the computer, and it generates a score based on a little bit more information for them. And it scores them 2 to 5 based on the mortality rate from the data that's put in. So it's a little bit more complex, but it comes up with very much the same outcome. And you can see that if you use a risk prediction score, you can actually treat patients more effectively in the community. And this study here showed that in France, they used a PSI score, and they found that a greater percentage of patients were actually managed at home once they started using this score in the A&E, and a far greater proportion of patients did well with oral antibiotics rather than being admitted to the hospital. So severity scorings are useful worldwide, but they do need to be used with clinical judgment. And these are some of the ones that are used throughout the world. So we've got here one called Smart COP, that's used in Australia. The PSI is used, as we said, in France. There's another one called Port, used in America. Here they've got the IDSA and ATS. And right in the middle of it all, you can see the curve 65. So it's pretty good. It's a pretty good marker of severity. It's quite easy to do. It doesn't require a computer. You don't need a lot of data. And on average, it gives pretty good comparison results to working out the severity score. So always remember your curve 65 score. Other things that make a difference to mortality outcomes are the speed at which you give antibiotics. And this study showed that if you give antibiotics quickly, within 4 hours, you can reduce the 30-day mortality quite significantly. And this has been taken up by the BTS and throughout the world in all the respiratory journals. And they always try and recommend that we give antibiotics within 4 hours. Now, this does lead to problems. We can't always get a chest X-ray within 4 hours. And as you know, to make a diagnosis of pneumonia, you have to have symptoms plus an abnormal X-ray. And if you can't get the X-ray within 4 hours, it's very hard to achieve that. So throughout the world, everyone has been trying to get antibiotics in quickly. And as a result, we sometimes over-treat in A&E. So there is a risk often that we give antibiotics in A&E before the chest X-ray, and not everyone needs it. So when you're clerking the patient in, remember, A&E may have given antibiotics because they're trying to meet these guidelines. And if the X-ray doesn't show consolidation, you don't have to continue them if you don't think the diagnosis is pneumonia. So I'm just going to talk a little bit more about pneumococcal or streptococcal pneumonia that we've been discussing. It's found in humans mainly. It's not found in any other animals throughout the world. It's seen in all age groups, and it's found in the nasopharynx of young children. There are about 90 different serotypes, and the transmission rate is particularly high in young children. So they spread it usually in nurseries. They spread it to their parents and their grandparents. And this is one of the serotypes you can see. In this case, it's serotype 19. It's got quite a thick coat to it, and it sits in the nasopharynx, and it's got all these flanges around the edge to help it sit in the nose and in the throat. This is serotype 3. You can see it's got a really thick outer border, and this protects it from antibiotics. So it sits in the nose, it likes sitting there. And unfortunately, when the person then goes on to get a virus like COVID, the nose becomes inflamed and the pneumococcus gets into the respiratory tract, and that's how it causes pneumonia. And in young children, they shake it off quite quickly. Their immune system's generally quite good, and they get rid of it. And their parents often feel a bit unwell, but they get rid of it as well. It's the poor grandparents who unfortunately get the pneumonia that suffer from it. And this is why it's so important in our grandparent population, particularly in Hastings, where they all, go to schools to pick up their grandchildren from school while their parents are working. It's so important to protect them by giving them vaccines to prevent them getting the virus, which then leads to pneumonia. And you can see here, the different serotypes do cause different types of mortality rates. And serotype 3 is one that is particularly high in terms of causing mortality. And we think that the thick coat around it prevents antibiotics getting into it and killing it. And as a result, it causes necrotic pneumonia much more than other serotypes. And this shows you here on this slide that serotypes 3, 6, 19 and 23 led to more patients having severe pneumonia and requiring intensive care. So, and you can see the pathophysiology of why that happens. They've got a particularly thick coat and it stops the antibiotic getting in to remove the pathogen. However, unfortunately, if you're over the age of 70 and you've got lots of other comorbidities, your risk of getting ill from pneumonia is quite high. And this slide compares the purple slide, sorry, 1 second. I just put that down. So this slide compares the younger age groups from 50 to 64 to those over the age of 65, and the red bars are those over the age of 65. And you can see the incidence of pneumonia is much higher in those over the age of 65. But then if you look at the first bar, it's those over the age of 65 who don't have any comorbidities. So there is an increase over the age of 65, but it's much, much higher if the person smokes or they've got chronic respiratory illnesses like COPD or asthma. You can see asthmatics, unfortunately, are a much higher risk profile of getting pneumonia. And then you can see other conditions like diabetes and alcoholism also increase the risk. So age is a risk factor, but so is comorbidities, and unfortunately so is smoking. So it's particularly important to advise a patient who's come in with pneumonia to stop smoking, because it'll reduce their risk in the future. And of course, another important way to reduce the risk of pneumonia is to encourage our patients to have a flu vaccine every year. And now we have COVID, to have the COVID boosters. And you can see here, before we had COVID, we used to give flu vaccines out, and this one was called Pneumovax vaccine. And you can see, compared to placebo, it significantly reduced the risk of pneumonia, particularly in serotype 3. So anyone who has grandparents who look after children, always encourage them to have the flu vaccine, because it reduces their risk of then going on to get pneumonia. Now, this slide really talks about the fact that you need to think about macrolides when you're giving antibiotics to people who have a severe risk profile of pneumonia. So if they're coming in with a curve score of 2 or more, our guidelines are to give 2 types of antibiotic, one of which will be a macrolide. And the reason for that is this study in 2008, which showed that macrolides reduce inpatient mortality. And as you can see, unfortunately, as time has gone on, the pathogenesis of pneumonia has developed, and a lot of streptococcal pneumonia is now resistant to erythromycin and increasingly clarithromycin. So if a patient is already on azithromycin for COPD, please consider this and send a sputum sample off early. So if they do have a resistant profile, we know of it and we can adapt accordingly. All of the respiratory guidelines around the world have recognized the importance of following a guideline to reduce mortality rate and to standardize treatment. The many benefits from it, from doing this. If we all follow the same guideline, we're much more likely to have a better general population outcome and a shorter length of stay in the hospital. And as you've all seen over the last couple of months, our hospital resources are finite. They're very important to the community, and we want to make sure that each hospital bed is used appropriately, so that if we do have a large influx of patients who have other problems, or we have another variant of COVID, we can manage that. So using the guidelines helps us use our resources effectively. Now, the last part of my presentation is going to be a bit about what happens to patients who have pneumonia after they leave the hospital, and you may not be aware of these outcomes. And then we're going to talk about the BTS audit. So as you've all seen with COVID, it's an inflammatory condition that causes a serous response, and so does pneumonia. And anything that causes inflammation in the body does increase the risk, unfortunately, of increased atherosclerosis and inflammatory plaques breaking down within atherosclerotic blood vessels. And you can see here the risk of getting pneumonia and going on to get a heart attack in the next 3 years is actually quite high in those over the age of 50. And this study found that in 2015, and it's been seen every year since, and after COVID we're seeing it as well. So remember, patients over the age of 50 have an increased risk of stroke and heart attacks up to 3 years after having pneumonia. And the way that it does this is that when the person comes into hospital, they obviously have if they're septic, they have a high inflammatory response, they have a high oxygen demand, increased cardiac output, and unfortunately, in patients who've already got atherosclerosis, the demand might exceed the supply, and you may see patients developing heart attacks as an inpatient if they're very septic on intensive care. This study looked at patients who died after having a pneumonia and a heart attack in hospital, and they found that the streptococcus had actually got into the myocardium. So it's not just COVID that causes cardiac problems. Pneumonia and streptococcus does do it too if their patient's very septic. And if they manage to leave the hospital from pneumonia, and remember that increased atherosclerotic inflammatory response leads to increased risk of heart attacks in the future. So do advise your patients when they're going home to stop smoking, and give them advice to try and reduce their cardiovascular risk profile. So in summary, remember, streptococcal pneumonia is the most common pathogen worldwide. Use the Curve 65 protocol to try and risk stratify your patients, see whether some of them can be managed at home, but always use your clinical acumen as well. Take a good social history and try and work out if the patient's able to follow advice for oral antibiotics. And if they're scoring 2 or higher, their mortality rate is quite high. So do make sure the right microbiology samples have been sent off, and put them on the correct antibiotics for that risk profile. Remember, the encapsulated serotypes like serotype 3 often evade antibiotics and cause patients to deteriorate very quickly and need intensive care. And macrolide resistance is increasingly common, so sending a sputum sample early can be quite helpful actually in patients who are deteriorating in hospital. We can give better microbiology profile treatments. And remember that when your patients go home, do give them advice on how to reduce their risk of cardiovascular consequences in the future. So ask them to stop smoking, and try and encourage them to have flu vaccines in the future. Now, we did a BTS audit in 2019, both at Conquest and at Eastbourne, and we were really hoping to be able to share that with you today. Now, we did very well in some parts of pneumonia treatment. For example, our A&E were amazing. They gave almost everyone, I think we were the highest in the country for giving antibiotics within 4 hours. Everyone got antibiotics. We did very, very well. And as a result, we had very few readmissions and very few deaths compared to the rest of the country, where less than 10% of patients died in hospital. And we had very few readmissions. But the things we didn't do quite so well at in the patients who came into hospital was documenting the curve 65 score. And this is important because the microbiology that we send off for patients in a low risk profile compared to a high one is different, and the types of antibiotics are different as well. So what we did to try and improve for the future was to give a series of talks, which we've done to A&E and for you today and throughout our doctors' training on bed ward. And we've created this bundle, which I hope you'll all be able to follow if you're in A&E or clerking a patient in MAU. It starts off with how to make the diagnosis of pneumonia. So at the top, it'll say the patient has to have symptoms, so a cough or fever, plus an X-ray. And then the timeline then starts from their admission. So within 4 hours, really, we should assess their curve 65 score. And I've put it there on the poster for everyone to follow. And then underneath, we've put in which microbiology test goes with which curve score. And to make it easy for everyone, all you need to do is to type in CAP into the eSearcher microbiology search. And the microbiology department have very kindly made it very, very easy. So if the score is less than 2, you tick that box and the computer will automatically generate the microbiology tests that go with a score less than 2. And you can print them all out in one go without having to search for them all. And of course, curve score 3 or more, they'll print out the Legionella or the more unusual causes. So it's much easier to test for early. And we're going to be talking to the A&E triage nurses as well to see if they can send some of these tests off if the X-ray is back early. And then underneath, we've got the microbiology antibiotic guidelines for each curve score. And this has changed since the last BTS audit. So patients who are score 0 to 1 get amoxicillin if they're not penicillin allergic. And those 2 and above, because of resistance profiles, we're giving comoxiclav and clarithromycin, but there's changes to those who are penicillin allergic as well. So we've put the levofloxacin in, and we've put the doses in to make it really easy. We've also given advice for patients who are pregnant. So it's a quick way of getting the guidelines if you're in A&E and you just want to refresh your memory. And then finally, at the end, we've put a little bit about patient education. So point them towards the British Lung Foundation information leaflet about pneumonia and encourage them to have a vaccine, and try and tell them a little bit about the pathophysiology of pneumonia. And if they're grandparents who pick up their grandchildren from school, encourage them to say the virus often leads to the pathway that allows pneumonia into the lung. So protecting yourself from the virus will protect yourself from pneumonia in the future. So that's our bundle. We're going to be re-auditing again at the beginning of May, the first 2 weeks of May. And the team working on bed ward and MAU and A&E are going to be leading on this, and they'll all be contributing to our BTS national audit. And the hospital here today would like to use it as a sequin as well. So it just shows good practice, standardized practice. So if you'd all like to get involved, it's quite good for your portfolios to have a national audit and a sequin as part of improving patient care. Right, so I'm going to stop there and ask if anyone has any questions. So Ollie's going to help tell me your questions because I can't actually see the chat on here. So does anyone have any questions about what we've been discussing today? I'm not sure if anyone's got a microphone or... Yes, if you haven't got a microphone, don't worry, just put a question into the chat and we can answer any of it today.
No questions at present.
No, I think a lot of the people attending actually are from the respiratory team, so all our team are well versed in this. They all know about pneumonia and how to treat it. So I'm just wondering if there's anyone from Eastbourne on the call, because we'd like to try and get this going in Eastbourne as well. Dr. Fonseca, do you work in Eastbourne? I think you work in Eastbourne, don't you? Because we'd like to try and run it in both sites eventually. So I know my respiratory colleagues in Eastbourne are quite keen to get this going there too. But it's nice if the other teams are aware of it, because everyone's on call. It's a common acute medical reason for admission and patient attendance in A&E. So if anyone would like to be involved in this project, please do email me afterwards. My email address is thereza.christopherson1@nhs.net. As I said, it's an easy audit for us all to do together. It's easier for a big group of doctors to do it because it's less work for everyone. And obviously it's good for your portfolio because it's a national audit, and also the hospital are now going to lead it into a sequin. So if you need a sequin for your portfolio, a sequin is something that shows improved quality of care and standardized care. And it's a very important thing to be able to do nationally. So if anyone's interested in contributing, particularly if you work in Eastbourne, please do email me afterwards, and we'll be delighted to have you involved. And I think we've met our time limit now, so I think we'll probably finish there if that's all right, Ollie. If there are no questions from anyone.
No questions that I can see, so thanks very much.
You're welcome. Okay, have a good day, everyone. Bye-bye.
Bye.